As a neonatal nurse practitioner since 2009, living and working in Colorado, she is faced almost daily with counseling families about marijuana use during pregnancy and breastfeeding. Her nursing education began with an associate's degree and continued to a bachelor's and master's in nursing more than 25 years later, finally finishing with a doctorate of nursing practice. With more than 40 years in healthcare, beginning as a bedside nurse in the ICU, CCU, emergency department, and neonatal ICU settings, she has had the opportunity to interact with patients and families with varying opinions and practices regarding the use of marijuana. These interactions have expanded in scope and increased in number as medical marijuana and legalized recreational use arrived in Colorado. Optimizing outcomes for patients has and always will remain her driving force in practice when a clear need to continue educating providers and families in her community arises. So welcome, Leeann.
Thank you. Hi, everyone. My name is Leeann Blaskowsky, and I'm a neonatal nurse practitioner currently working as pediatric hospitalist through the CU School of Medicine. As much as it terrifies me to admit, I've been a nurse for nearly 40 years, working exclusively with babies for the last 20 of those years, which should tell you that I can and do talk about babies all day long. Babies are literally my business, and I have made it my business to speak for those unable to speak for themselves. I have no relevant financial or research-related disclosures on this topic. Although I am currently employed by the CU School of Medicine and Children's Hospital, Colorado, my discussion today does not represent the opinions of either institution. During my discussion today, I'll be reviewing some basics on perinatal exposure to cannabinoids and its impact on fetal and neonatal development. I'll then speak to how legalization has impacted use during pregnancy and review some evidence-based discussion points for you to take to your practices and communities. Before I get started, a little shameless advertising, if you'll allow. The path getting me to here is just a tad unconventional. My husband is retired from both the Air Force and law enforcement. The remnants of his service left him with some long-term ankle, knee, and back issues. He was seeing Dr. Finn for these issues and happened to mention his wife, that would be me, was an NNP. They chatted over several sessions, and Ken reached out to see if I might be interested in collaborating with a few others in the field to write a chapter in this new book he was putting together. We met at a Starbucks, of course, because doesn't everybody, or at least we used to before COVID. And he told me about this project and his plans for the information he wanted to convey. I believe at the time there were 4 or 5 others he had recruited for this particular chapter. But you may notice that the chapter lists me as a solo author. I still think it was one of those everyone else stepped back and I was the last man standing, but here we are. The book contains an insightful foreword written by Dr. David Murray, a senior fellow with the Hudson Institute in Washington, D.C. The rest is an incredible amount of evidence-based information from experts around the globe. I hope that after today, you will be curious enough to get a copy, read it, and share the information with your colleagues in practice, along with friends and family members too. In the inimitable words of Cheech Marin, one half of the well-known comedic acting Cheech and Chong duo, this ain't your granddad's pot, and this book details that. Okay, whether it is smoked, vaped, or eaten, let's drill down on prenatal and perinatal cannabis exposure. As an aside, although I think the green color of that Kif Caf bar might have stopped me and made me take a second look, can we just look at the labeling on some of these products, like the tarts or this cereal? That is an accident waiting to happen, especially when children are around. As this diagram illustrates, many areas of the brain are impacted by delta-9 tetrahydrocannabinol, or THC. And if you guys will allow me, I'll continue to use THC because I might not have had enough caffeine to keep saying that. When it attaches to the receptors of a fully developed brain, each of these areas can be affected when exposed to the chemical compounds found in marijuana, a physiologically global impact. One thing that frequently gets lost in any discussion is the fully developed part. This brain isn't fully developed until about age 25. To give some real world perspective, do you think it's a coincidence that your car insurance rates decrease at the same age? Insurers understood overall brain maturity isn't set until then, and the propensity for risk-taking behaviors decreases, impacting their bottom line. These neurons are beginning to form from the moment of conception and continuing by the billions until that magic age of 25 is reached. Without belaboring too many points that you've likely heard before today, I'd like to take just a minute to review some of the chemical properties of marijuana so that we are all on the same page when we look at prenatal and neonatal exposure. All mammals have an endocannabinoid system with varying concentrations and locations of receptors within the nervous system. Science has demonstrated these receptors are responsible for memory, concentration, time perception, pleasure, and play a major role in normal neuronal development. The functions shown here for motor learning, appetite, and pain make it easy to see where the medical applications for marijuana may have originated in nerve and movement disorders like Parkinson's that took my dad, and in oncology care to help with pain management and appetite stimulation with chemotherapy side effects. Several friends are involved in that particular branch. These CB receptors, normally occupied by endogenous chemicals, get bumped and replaced by THC, which has a very similar makeup as shown here. Altering these processes and pathways leads to what may very well be global dysfunction. So here's how THC affects a matured adult brain. It impairs judgment and attention. Definitely a good reason why you shouldn't drive while you're high. Also, a thought for altered parenting skills in postnatal use. It impairs balance and coordination and can alter time perception and your short-term memory. There are additional psychological effects like fear and anxiety, personality disorders, or at the extremes, psychosis. I don't know if any of you have personally witnessed a psychotic break, but I have during my time in the emergency department, and it can be truly terrifying. These psychological effects appear to be enhanced in adolescents and young adults. A meta-analysis published in the American Journal of Psychiatry in 2020 found an association for increased physical violence across numerous studies that included nearly 300,000 subjects in the 30 arms they developed from the more than 11,000 studies they screened. Their results demonstrated at least a moderate association between cannabis use and physical violence. Some studies report that cannabis use before brain maturation by adolescents may cause disruption of the normal brain maturational processes and lead to long-term issues with cognitive control. And a newly emerging condition that presents as intractable vomiting continues to rise in emergency departments across the country, now known as cannabinoid hyperemesis syndrome. But wait, isn't cannabis being recommended to stop pregnancy-related vomiting? Now let's look at the onset of THC effects. How you get it matters, at least in the fully developed brains that we've been able to study. Inhalation usually nets almost immediate effects that can last up to 3 hours and also delivers significantly higher bloodstream concentrations than ingestion. Ingestion takes a little longer for the effects to display, a danger unto itself, and can last up to 4 hours. With delayed onset, it can be very easy to get too much. especially if the user isn't paying attention to the serving size. Who hasn't heard a news headline or heard a movie storyline about someone eating an entire cookie with a recommended serving size of 1/8? A mistake easily made because seriously, who eats an eighth of a cookie? Not me. What we don't know is how exactly this impacts the developing brain or the unique physiology that belongs to infants and children. The first thing we are taught as medical professionals learning pediatric care is that children are not little adults. They are vastly different, both physically and physiologically. Okay, so whether anticipated, carefully planned, or a complete surprise, the test is positive. At-home pregnancy tests are advertising they can accurately diagnose pregnancy before you even miss a menstrual cycle. The potential for marijuana use before awareness of pregnancy is very real, and given its accumulation in fat tissue with irregular release, persistent exposure well beyond actual cessation. You make an appointment, your provider reviews your health history, confirms your at-home test, and hands you a long list of what to avoid and a very short list of what's okay to take while you're pregnant. Although the American College of Obstetrics and Gynecologists, ACOG, recommends that pregnant women not use marijuana during pregnancy, providers will often choose this as a pick your battles moment. They will say, I want this patient to continue seeing me, and if I press this issue, they won't seek prenatal care at all, and outcomes could be even worse. And without subjecting every OB patient to random screens, there really is no way to monitor use during pregnancy. Cannabis is readily available in 38 states, at least as medicinal and/or recreational, up from 30 just 3 years ago. Colorado being among the first to legalize recreational use in 2012, with more coming every election cycle. And then the fun starts, except it's not so fun, is it, for any ladies in our virtual room? The morning, noon, night sickness, the aches and pains. But wait, isn't marijuana supposed to help with nausea? You may recall me mentioning cannabinoid hyperemesis syndrome. It actually has an ICD-10 code, F12.188 for my fellow medical nerds. So what's a mama-to-be to think? Here's a hypothetical situation to ponder. My name is Sarah. I'm 23 years old, live in Colorado, and I'm pregnant for the first time about 7 weeks along. The nausea is so bad, I can't even begin to think about eating. And when I force myself to try, nothing stays down. My friend Nancy said she used some marijuana edibles in the first trimester just so she could eat, and her baby is fine. The guy at the dispensary down the street said it was okay. My doctor didn't say it wasn't, and it helped. But the data is starting to show otherwise. ACOG issued a 2017 statement that includes, among other things, discouraging marijuana use while pregnant, since it is known that THC crosses the placenta. This statement also specifically mentions that THC may disrupt normal brain development. The statement further advises women to ask their provider for FDA-approved treatments for the symptoms I've mentioned. Volkow discussed THC's interactions with those type 1 cannabinoid receptors in the dorsal vagal complex. She further writes that women are turning to marijuana at the time of greatest risk to the fetus, the first trimester. So let's do a little deeper dive into this assertion. First, let me say this is not an intensive review of embryology or pathophysiology. We don't have the time, and I am not sure I have the strength for that one. But I'd like to bring your attention to the little picture in the lower left corner of this illustration that is labeled 100 days and outlined in red. A landmark in a presidential term, there is even a special speech to mark this accomplishment. Or in your child's school year, you know, all of the littles picking a 100 based theme for the day. love the pictures of the kids dressed as little old people with walkers. This time frame is also roughly equivalent to the first trimester of pregnancy, 14 weeks actually. Brain cells are forming at a rate of about 15 million cells per hour during those first 12 to 14 weeks. So let me ask you this. With a virtual show of hands, I think you have to go to that little ellipsis in the lower right corner. Who used some sort of navigation technology to get somewhere today, or at least in the past month? That's a pretty fair number of you, and myself is included in that. And when you make a wrong turn, what happens? It recalculates, right? Now that's technology and this is physiology, but with all of these complicated and convoluted processes happening on very precise timelines, as illustrated in this picture, do you think things might go wrong if chemical insults, those wrong turns, are introduced? And like it or not, despite all the assertions about cannabis being organic, it is a chemical. Remember the data about adolescents altering brain maturation with long-term lasting effects? But we'll talk about the simplicity of rocket science a little later. Now, I know I promised nothing as dry as pathophysiology, but we do have to touch briefly on some interesting information emerging in the field of epigenetics to better understand the potential effects of prenatal marijuana exposure. Human development has long been known to be impacted by the hypothalamic pituitary adrenal, or HPA axis, which is responsible for neurotransmitter release. Exposure to cannabis can cause a downregulating of the endocannabinoid system, inhibiting neurotransmitter release. These neuronal building blocks are essential for brain development. Lowe and colleagues reported the expression of endocannabinoid receptors had been demonstrated in the fetus as early as 5 weeks gestation. These receptors are also found in both male and female reproductive tracts, suggesting a potential role in regulating reproduction and possibly impacting fertility. The downstream effects are just now beginning to be revealed, some discussing that global brain impact as well. The studies are ongoing, and the results of the ABCD study published in 2020 are associating greater risks for psychopathology during middle childhood too. In the 1950s, Dr. David Barker theorized that in utero programming literally caused remodeling at the cellular level and was indeed the major factor leading to future disease. Roseboom's 2001 work studying the effects of the 1940s Amsterdam famine on adult mortality further illustrated this proposal. Because both genetic and environmental factors are at play, more work still needs to be done. Indeed, several studies have linked marijuana exposure to lower birth weights, preterm delivery, and longer hospital and NICU stays, but there may be even larger concerns looming on the horizon. Cannabis exposure before and during pregnancy, as demonstrated in fetal brain specimens studied after elective abortions at 18 to 22 weeks, has been shown to alter epigenetic programming implicating the development of autism spectrum disorder, attention deficit hyperactivity disorder, schizophrenia, addiction, and other psychiatric diseases. Colorado is well known for pioneering in many areas, marijuana legalization, in my opinion at least, being a less than shining example. But I suppose that is what is at the heart of many debates. In 2000, Colorado voters approved the use of marijuana for certain medical conditions with the approval of a physician. Dispensaries proliferated but were strictly regulated for those who gain access to shop and purchase product with a card system. Securing a card, however, became fairly easy. Then in 2012, voters approved recreational marijuana use, legalizing use for those over age 21 and limiting possession to 1 ounce. Then in 2019, Governor Polis enacted the decriminalization of several drugs, including marijuana, still federally listed as Schedule I, making possession of up to 4 grams a misdemeanor instead of a felony. As healthcare providers, we all know that the drug under discussion and its potency can drastically impact any quantity equivalency discussions. I will show you what has happened with THC a little later. This realization was made clear in further legislation passed just this year, decreasing the possessable amount of fentanyl, a drug known to have significantly greater potency and harm potential, to 1 gram. That's 1,000 milligrams. And for a drug that can kill with as little as 2 milligrams or less, it's still too much, but that's a topic for another discussion. If I could beg your indulgence for just a minute. As a mom who has lost her son to fentanyl poisoning, I have firsthand knowledge that potency counts. Without veering too far off topic, my son Andrew was found to have what is classically recognized as a subtherapeutic level of fentanyl when it is prescribed for pain management in his system. But because it was combined with a benzodiazepine, the Xanax he thought he was taking, in what was likely his first exposure, making him a novice, that ultimately took him from us in February of 2020. The debate about marijuana as a gateway to more potent drug use and addiction rages on. And again, from our personal experience, our son started with just a little, now legal, weed now and then, his words, and then to help him settle his nerves. That's him over my right shoulder in the picture that came attached to the reminder for this presentation. Did cannabis make a difference for our son? Is there a direct link to future experimentation like Andrew or addiction? Many questions remain unanswered, not just for us. Okay, now back to our discussion. Across the country, more states are legalizing the use of marijuana, whether medical or recreational. The olive green represents those states with both medical and adult recreational use. The Kelly green with medical use only, and the pea green, I know why they picked green, but they could have picked different shades, my opinion. The pea green with CBD or low potency use programs. State governments, however, are largely not addressing the exposure during pregnancy and breastfeeding issue. And everyone seems to be ignoring that marijuana remains a Schedule I drug and therefore federally illegal in any form, which means that although the drugs are available for use, the ability to study them and their effects is complicated, if not impossible. While we're discussing legalization, let's take a little closer look at how that translates. Several authors have pointed out the rise in use among pregnant women in states where marijuana has become legal. Fine and colleagues have published data in the March 2019 issue of the Journal of the American Medical Association Psychiatry that report a 75% increase in past month marijuana use among pregnant women between 2002 and 2016, 75% increase. The most recent data from Drs. Reese and Halsey, detailing figures obtained from the Centers for Disease Control, report 24% of California teenage mothers test positive for cannabis. So this isn't just a Colorado phenomenon. Another California study demonstrated a measurable use increase with closer proximity to retail locations. Admittedly, more study is needed to eliminate confounding factors, such as retail location placement in communities that are more likely to purchase, because who's going to put a store where no one will buy their products? But the data is emerging. Is there a link between seeing a dispensary and giving it a try? In addition to the increased use that legalization has brought, the concentrations of THC within the available products have increased over time, and there is little or no regulated production. The last graph demonstrates that legalization has also brought a rise in hospital visits seeking treatment. I'd also like to like you to give some thought to a legal catch-22 here in Colorado. In Colorado, statutes specifically address that when an infant tests positive at birth, remember marijuana is still Schedule 1, and defines those infants as neglected, but pursuant to Colorado Revised Statute 13-25-136, in an effort to reduce the risk of prosecution of pregnant women, no information obtained as part of screening for prenatal care may be used in any criminal proceeding, less likely to even be a factor with the overarching decriminalization. Oh, now don't get me wrong, at the institutions where I've worked over the years, urine and now cord segments replacing meconium as the standard are collected and tested for anyone who presents with limited or no prenatal care, has a placental abruption, which is a known result of substance use, but not the only cause for this problem, or self-reports substance use during pregnancy. This routine is generally implemented to address concerns for profiling and inequity. Members of the social work team will then monitor results and make a DHS report if indicated, but in the absence of other concerning factors, if results reveal only THC, no report is likely to be made. As of April 2019, Colorado has added autism to the list of indications for medical marijuana without age restrictions. Just let that sink in for a moment. We've been talking about how neurons are forming by the billions and how they continue to form during childhood and adolescence. And now we've made it okay to introduce more potential harm with as yet unstudied chemical insults that may very well be implicated in causing them in the first place, according to the latest data discussed by Dr. Stuart Rees from Australia. So we're being watched from around the globe. Our legislators have also recently been considering a bill requiring shops to post warning signs against use while pregnant or breastfeeding. This one is from Washington State. A sign might not seem like much, but a considerable percentage of these retailers have been recommending marijuana for use in both, and it is at least a step in the right direction. Dixon and colleagues conducted a statewide cross-sectional study using a mystery caller approach, and about 70% of them actually recommended cannabis during the first trimester. And that was a study conducted here in Denver. The study also reported that few dispensaries encourage discussion with a provider unless they asked, should I check with my doctor? We, as healthcare providers, must be the voice to bring clarity to the information that is available. Information can be found literally at the push of a button and a few clicks of the mouse. Your patients will have information. Do you? They will tell you about what they have found, but are you prepared to have an evidence-based discussion? Here are just a few things I hope you will find helpful. Another show of virtual hands. Who has gotten the Jamaican study tossed around by parents? That ethnographic field study compared the prenatally exposed infants of 24 cannabis users to 20 non-users in Jamaica at 1 and 3 months of age. Now, I'm not sure what you learned in research class, but I learned a lot about population sizes and bias. This was a very small subset in a very selective setting, decades old, and looked at a very narrow window in developmental time. Yeah, sure, you can say these babies weren't born with 3 arms or missing an organ, But what you can say about overall learning and ability to focus, but what can you say about overall learning and ability to focus at 3 months of age? That's not to say that there are a number of large randomized studies for you to counter with, but the information is growing. Now, on the other side of the coin, who has used the 8 times concentrated in breast milk argument? I did, until I discovered that was from one study from 1982, which doesn't seem that long ago to me because I was there, but it really is, medically speaking and research speaking, where researchers simultaneously tested a breastfeeding mother's blood and breast milk. The milk was found to contain levels of THC 8 times higher than her blood. But a little clarification needs to accompany that information. First, she was a regular heavy user, up to 7 times a day. I don't know how you afford that. Recalling that THC is stored in fat, some dose-dependent influence must be considered. Second, she is far from representative of the general population, and if you approach your patients with misleading information, they will be less likely to hear anything else you have to say. There is a very small, more recent study from 2021 conducted by Moss and colleagues that appears to confirm the concentration within the breast milk compared to maternal serum levels, but with variable expression. But here's what we do know. This is the rocket science I mentioned earlier. THC is lipophilic, meaning it is attracted to fat. We also know that breast milk is approximately 80% fat. Any keto followers out there? That makes breast milk the perfect food, right? We all learned that. We do know that THC will pass into breast milk. What we don't know is how much over what period of time. We also do not know how much, if any, is safe for a breastfeeding newborn, but we're working on finding out, and so far, it doesn't look like there is any amount of safe exposure. The little box in the lower left-hand corner of this slide is a 3D ultrasound of my grandson at just 5 weeks, about the time those neurotransmitters are forming with a potential for long-term outcomes. So let's get the discussion going. I start with a general screening question that I ask every new mom I contact in my current role. Any exposure to alcohol, tobacco, marijuana, or other drugs during the pregnancy? Asking open-ended questions helps with reducing a paternalistic approach, well characterized and historical in medicine. Next, I'll ask about frequency and duration of exposure. And you'd be amazed how many people will not hide their use because they care about what happens to their baby or has happened to their baby. I often hear the use was before awareness of pregnancy. Sometimes it's during the first trimester for morning sickness, which tells me they either chose not to follow their provider's advice or I need to have a chat with their provider. For still others, it is throughout the pregnancy, for the nausea and vomiting, and then for the aches and pains, or insomnia, or appetite, and may have been just the day before delivery, if not the day of. This is all helpful in guiding the remainder of the discussion. If there is any self-report of use, the discussion turns to plans for future use. If a mom tells me she used before she knew she was pregnant, I ask if she plans to resume her pre-pregnancy use. I will say I am not the marijuana police and I will not be there to monitor your use. And I know you want to do what's best for your baby, but you are the one that gets to decide. I then add the information we know that I just mentioned about THC crossing the placenta and entering the breast milk. And I use the words rocket science in the discussion. Although it may seem strange to talk about the placenta now that the baby has already been born, but it is an opportunity to educate for future pregnancies or parents' circle of friends. We will talk about different choices like using formula if she feels her marijuana is essential and concerns for impacts on parenting if parents are using mind-altering substance. I have a tendency to deflect tension with humor, as you may have noted in this discussion today, and bring it into my discussions. Sometimes that doesn't work, but most often it does. If nothing else, I hope it gets them thinking. I'm sure for many of you, this isn't the first time you've seen this. And I know this has got to be Photoshopped because although on some days it looked and felt like there was an alien attack going on in there, this was not something I ever experienced. It does serve, however, as a reminder that there is another person involved in this decision. And as healthcare providers, we are tasked with caring for all of our patients. In this case, the mother-infant dyad. The US Surgeon General issued an advisory in 2019 confirming the potential harm to the developing fetal and neonatal brain. The CDC, American Academy of Pediatrics, and American College of Obstetrics and Gynecology are also recognizing this is an issue. But will it be too late for an entire generation? It is incumbent upon us to ask, inform, and continue to investigate, and then share what we know with our colleagues in forums like this. Thank you all so much for your time and attention today. I'd love for you to reach out with any practice pearls that reach for you. And Karen, if we'd like to open it for discussion, I wanted to leave lots of time for that. And if anybody's interested, I do have in the slide deck the resources that I talked about.
Okay, well, thanks so much, Leeann. This was an eye-opening presentation with a lot of information that I'm sure we'll all be thinking about for days to come. So we can get started now with our questions and answers. If everyone would please write your questions. I see we have one here. And this is from Ellie. Do we know how much passes through the placenta?
Like an actual gradient. I don't know that anybody has looked at specifically percentages. Again, it's going to depend on duration, dose, exposure type, whether it was inhaled or ingested. As with any drug, the inhalation gets it into your system faster at a greater rate. The placenta works by passive diffusion, so it will get in there. And the studies that show that there are greater concentrations in blood than in what gets to the baby are still in process.
Okay. Another question, can you restate the code, the medical code used for CHS? I think it was the code that you mentioned earlier.
I'd have to go back through the slides.
Okay, well, we can come back to that. We can circle back to that one in just a minute.
Sorry, I don't have it memorized.
Not a problem, not a problem. Julie says that it's mandated in Colorado to have a sign that no known amount of THC is good for the unborn or breastfeeding women. And
I don't think there are any mandates on the size of that sign, though. I could be wrong, Julie.
So another question is, are you seeing the same concerns on hemp-derived THC like Delta 8 or 10?
I didn't look specifically into those. I'm sure there's even less data available on that. But it is the Delta 9 tetrahydrocannabinol that is known to alter neuronal pathways. I'm sure that there are studies out there. I just didn't look at
Okay, let's see. First of all, I wanted to answer that everybody, we are going to be sharing the PowerPoint and the presentation recording in the next few days. So you'll get that. Everybody who's registered on this webinar will get that. So I know there's been a lot of questions on that. And there's another one here. Are there some talking points that we can use with obstetricians who are saying it is okay to use during pregnancy?
Well, being that we are all now in evidence-based, data-driven practice, one would hope that just giving them the information. I know that there are some pamphlets available. Sitting down with a provider in a one-on-one meeting would probably be the best way to get their attention, because who among us doesn't look at an email, glance through it and say, oh yeah, I'll go back to that later, and never go back to it. We remember better in a face-to-face interaction information that's delivered. That's why we all have to sit through painful lectures while we're in school. Give them the information that's available. Feel free to share what I have here. Read as much as you can. Be prepared for the discussions and the questions. Highlighting, it was interesting when Karen first reached out to me. She said, how much time do you need? I said, oh, I don't know, an hour, a week, a year. I actually struggled with how long to make this, because I have this discussion on an almost daily basis, if not several times a day, but I have it drilled down to 2 minutes because I don't have that much time to spend with patients and parents. And I'm hopeful that the information that they get is concise enough that it makes them think and talk in those parent groups and go back to their OB. And most of our OBs are on board with no amount of THC exposure during pregnancy and breastfeeding is okay or safe. And the discussion of, well, I don't want them to stop seeing me, so I'm not going to belabor the point, but all we can do is give them the information. We're all given free will, and we have to make those decisions. I say on a variety of topics when I'm talking to parents that I'm not here to change your mind. I'm here to give you information so that you can make the best decision for you and for your baby, because you want what's best.
Right.
Does that answer your question?
I think it did. Leeann, can you back up your slide to your contact information? A couple people wanted to connect.
Oh, so sorry. Yep.
Just slide that back. So there's Leann's contact information. We'll leave that up here while we finish up. Let's see, there is another question here. If the father is a heavy marijuana user, can the THC be present in his sperm and affect the baby?
Interestingly, as I was researching for a little more information on this, for this discussion, there are several studies that are finding it in sperm. The unique association, properties of sperm is that, unlike mom's eggs that are actually there when she is developing in utero, so each of us are giving DNA to our grandchildren. It's kind of bizarre when you think about it. But sperm is renewable. Every ejaculate has quote unquote fresh sperm in it. So it would, again, it's theorized that it depends on dose, duration, proximity to ejaculate, and it's in there. And whether or not it's altering DNA, more and more information is evolving in a slightly related trisomy 21, the genetic anomaly that results in Down syndrome, for decades has been blamed on maternal DNA, and there's now several studies that are reporting that paternal DNA can have a factor in that, and it's more prevalent in over 55. I mean, over 40 sperm. So it stands to reason, it's an extrapolation, but it stands to reason that paternal use, in addition to, unless mom is hiding in a cocoon while he's heavy using, her secondhand exposure has potential for impact as well.
Okay. So I want to say one more time that we will be sending out the slide deck from this PowerPoint, and we will be sending you the recording. So I know people are continuing to ask that. So you will get this, and you just have to wait a couple days, and we'll get it out to you. So that's that. And then let's see. Oh, here's a question. Does the use of CBD oils also affect the pregnancy?
Great question. CBD oil, as I mentioned, with all of the marijuana related products, is not regulated. And labeling is just as unregulated. And although it says CBD oil, it could have THC in it. And classically, CBD does not contain the delta-9 tetrahydrocannabinol extracts in it, but I couldn't tell you exactly where I saw it, but I remember seeing and reading several instances where they actually did analysis and found in products that purported to not have THC in them, they did. I personally have achy knee joints, and I'm in a healthcare related field, so I could be subject to random drug screen. It makes me take Advil because I don't know. Even something that's advertised to not have any THC in it, it could be in there. And I can't afford to go get everything tested. So I just avoid those things. So the short answer is it could be. And without spectrograph analysis, it's kind of hard to see whether or not it's actually there.
Okay. Let's see. There is one other question here. Are there any current studies continuing to research on breastfeeding and THC levels? So things, I guess, research that's in progress that you're aware of?
They're trying. About the time that I wrote this presentation, I actually wrote this a couple of years ago. I was supposed to give it, and then COVID happened. But there was a planned study in Utah, and the funding got pulled. Keeping in mind that it's still federally illegal getting grants, getting approvals, because it is legal in so many places, and the general community awareness, it's not getting easier like I hoped it would, but they're trying.
Okay. And then there was a question about what is the natural function or purpose of the endocannabinoid system?
So the functional purpose of the endocannabinoid system is, if you could imagine exactly what marijuana is purported to fix, it involves pleasure and gratification, and part of the endocannabinoid system is why narcotics work, to take away pain, so pain relief. There is, I think I mentioned part of the endocannabinoid system with movement, which is why it would make sense that THC works for folks with Parkinson's and slowing down the tremors. There, and those endocannabinoid receptors, like you saw in that, I think it was the third or fourth slide with the brain, throughout the brain are endocannabinoid receptors. They're actually throughout the body. So each of those areas will have a different function. And that is probably a lecture that could take at least a whole nother hour for what each, the location and the function of each of those areas.
Okay. So we're kind of in a last, we've got a lot of comments that this was a great presentation and much needed information. So, and so that, unless we have any more questions come in, this will probably be.
Go find the book. It's awesome.
And let's see, do we have a link for that book? I don't know, Julie or Leeann, do you know, do you have?
It's published by Springer. And last I looked, it was still available on Amazon. I didn't want to make people go buy it.
And say again the name of the book. I know you had it up there, but the name of the book is.
It's Cannabis and Medicine.
Cannabis and Medicine. Dr. Ken Finn is the editor.
Yes.
Author, editor. I know there's a number of authors of sections,
yeah.
But Dr. Ken Finn is the lead author or editor on that. So Cannabis and Medicine. Okay, well, thank you so much. This was very interesting, and thank you for all your getting this together for us. I want to remind everybody we're going to be sending out invitations to our upcoming marijuana and pregnancy webinar series that'll continue next year. So you'll get those contacts or the emails on that. You can watch for that. And then just we'll have a survey come up here in just a few minutes at the conclusion of this. So please complete it and send it back. And again, we will be sending you the PowerPoint and the recording and also in a few days. So thank you all very much. And this will conclude our webinar.
Thanks, everyone.
Goodbye.
Bye.